Okay, so we just got done talking about the muscles of the pelvic outlet. And if we go back, for those of you guys that do know about, this is the urogenital diaphragm of the pelvic floor on the female and the male. And the only reason why I pulled this slide up is I don't want you guys to think that I disrespect the urogenital diaphragm, but I also want you guys to appreciate how an adductor, a hamstring, and a glute max are a lot bigger muscles. They're going to help to influence that pelvic inlet outlet position. And I think that these muscles are going to have a better function if you appreciate how big the other muscles that are controlling it. So I don't want you to think that I disrespect the urogenital diaphragm and how it functions with the pelvic floor. But you're going to have a hard time convincing this clinician that these little itty bitty muscles are going to help to control my pelvic floor function. And I think that if they get in a better position with my inlet and my outlet, they can be able to function better. So I'm only pulling this picture up because I want you to see who's going to have a more powerful influence on that pelvic outlet. These muscles or your adductor, hamstring, and your glute max. Look how big the muscles are. If you go back to your circle on page 15, we're going to talk about our anterior outlet. Remember, your anterior outlet is being pulled apart. Your left ASIS and your right pubic symphysis are being pulled apart. So you have 4 muscles that are primarily in your left anterior outlet. And those muscles are your puborectalis, your pubococcygeus, if you want to fill in your circle, your obturator internus, and your iliococcygeus. Those muscles are going to be long and weak because of your inlet position. They're not in an optimal position to work. They're not going to be strong. It's kind of like taking your elbow, and if you straighten out your elbow and your tricep muscle is long, it's going to be a lot harder to turn on your tricep muscle if this is in a lengthened position. These muscles are in a lengthened position, so they're a lot harder for them to contract concentrically and to be able to be strong and to be able to function. But it doesn't mean they don't have tone. In your left posterior outlet, your coccygeus, your piriformis, and your glute max are going to be short and strong. So here's my inlet and outlet position. So my posterior outlet is short and strong. So my right posterior outlet is going to be long and weak with your coccygeus, your piriformis, and your glute max. And your right anterior outlet is going to be short and strong. That's going to be your puborectalis, your pubococcygeus, your obturator internus, and your iliococcygeus. Any questions with the pelvic outlet? Remember that your left anterior outlet is going to be off. Your left posterior outlet is going to be on. Your right anterior outlet is going to be on. And your right posterior outlet is going to be off. Remember, your ons are what we are going to want to inhibit, and your offs are going to want to be what we want to facilitate. We're going to review. In a left AIC pattern, you guys are going to think about Emily. And Emily stood up here on her right leg and pulled her left inlet forward and her right inlet back. We love this position for right stance. But when Emily went over to stand on her left leg, she still stayed in this exact same biomechanical position. And when you're staying in this biomechanical position, some muscles are going to overwork for you, some joints are going to get compressed, and some people are going to create twist and torque, whether it be through a hip region, through an SI region, through pubalgia, through a low back. Because our body is not meant to stay in a right stance when we have two legs. In the inlet, you have an anterior inlet that is going into flexion, external rotation, and abduction. We're calling that iliopubo-external rotation. My left posterior inlet, my ilium is moving on my sacrum into internal rotation, or iliosacral internal rotation. We have a muscle back here that is long and weak in your left posterior outlet. From your sacral base to your left ASIS is being pulled apart, and that inlet position is causing your left iliacus muscle to be long and weak. In your right anterior inlet, from your right ASIS to your left pubic symphysis and the left AIC pattern is being pulled apart. You have two muscles over here that you colored brown. And those two muscles are also long and weak. We need to turn on our right anterior inlet and our left posterior inlet. These are off. And a left AIC pattern. If we go down to our outlet and a left AIC pattern, it's not your left posterior outlet that's off, it's your left anterior outlet that's off. So we have a left anterior outlet that's off, we have a left posterior inlet that's off. In a left AIC pattern on our right side, we have a right anterior inlet that's off. And we have a right what? Posterior outlet that's off. It's opposite, you guys. Off, off. Off, off. Because if we had two ons or two offs that are on top of each other, our patients wouldn't be able to walk. They could. They're going to walk with the back. They're going to walk with hip flexors. And there are people that walk around your store doing this because they're trying to get frontal plane through a what? Back. They don't have frontal plane through an inlet and an outlet. So what's our goals? This is going to be on page 18. This is a summary of what we spent the last 2 hours going through. You have your inlet. You have the muscles that are going to help out. Notice you have extension. You have a frontal plane, and you have rotation. So these are all the muscles that we went through earlier. But notice that your left hamstring can help out with iliopubo-internal rotation. Because if I was going to pull my left outlet into ischiopubo-external rotation. And if I pull my outlet into ischiopubo-external rotation, my inlet's going to go into iliopubo-internal rotation. So you're going to see crossover between the muscles. I'm not trying to create confusion. But this is a summary. You also have a summary of your outlet. Notice, you guys, that we want our inlet to extend. We want our outlet to flex. We want our inlet to adduct. We want our outlet to abduct. And you have different rotation. We want our left side to go into iliopubo-internal rotation. We need our outlet to go into ischiopubo-external rotation. It's opposite. So there's a summary page of everything that we went through. All the actions are written down for you. Here's a review. Please do not get overwhelmed with all of the acronyms. Iliopubo-internal rotation. So if we're going into iliopubo-external rotation, we're going into flexion, abduction, and internal rotation. It's the same thing posteriorly as iliosacral internal rotation. Your outlet is the same thing if we talk about the outlet position. If my inlet's going into iliopubo-external rotation, my inlet has to be going into ischiopubo-internal rotation because it's the same bone. And it's the same thing for those of you that have been to a PRI course, or when you look at our treatment handouts as AFER. And I'm not trying to confuse you guys with a lot of acronyms. I'm just trying to teach about an inlet and an outlet position. I want you guys to appreciate frontal plane, sagittal plane, triplanar activity of an inlet and an outlet so you know how to better treat your patients. And you're going to better understand why we have an algorithm of treatment. And you're going to better understand how PRI tests can help guide your treatment. It's a lot more than just doing an adduction drop test. Any questions so far? Our goal for our left AIC pattern patient is we want to get our patient more alternating. These people already know how to get reciprocal. I want you guys to think about alternating as an ability to get into right stance and left stance. Reciprocal is about being able to get on the same side in order to get something to flex and extend. Well, we have that. We have an inlet that can flex. We have an outlet that can extend. Or you can look at it in the frontal plane. We have an outlet, an inlet that can abduct. We have an outlet that can adduct. So we have reciprocal. What we don't have is alternating. They've got to learn how to get from their right leg to their left leg. So now I'm going to help you out so you guys understand our treatment tomorrow. We're going to go through each quadrant. What are we going to turn on, Lori, to help get our patients to help to inhibit a left anterior inlet and a right posterior inlet, or a right anterior outlet and a left posterior outlet, so I can get in a better position. This is what we spent. This is your inlet. This is your outlet. This is what you guys have filled in on your circles. This is your sacral base. Remember, your left iliacus is off. Your right rectus femoris and sartorius is off. If you flip this over, remember this is anterior, this is posterior, this is your outlet. Your left anterior outlet is off. So your puborectalis, your pubococcygeus, your obturator internus, and your iliococcygeus are off. That's part of your left anterior outlet. And your right posterior outlet is off. Your glute max, your piriformis, and your coccygeus. So we want to take all of our ons and make them go off, and we want our offs to go on. We want to get here. And once our patients learn how to get into left stance, they've got to be able to get into right stance and not fall apart and not stay stuck. Our patients have got to get reciprocal alternating activity once we teach them how to get into left stance, and we teach their right leg how to swing through the air and not be a leg whipper. And we can get them into a left stance phase of gait, a right swing phase of gait. Your treatment's not over unless your patient can get back into right stance and not what? Fall apart. They've got to be able to go back and forth. So if I want to create an alternating patient, and I go to my left inlet, I told you we need to turn on our right anterior inlet. We want to turn on our right rectus firmus and our right sartorius. And how am I going to turn those muscles on? We're going to respect position. So anytime I can pull my right inlet forward, I'm now going to put those muscles in a position to work on my right inlet. So if I pull my right side, if you sit in your chair, and if you guys pull your right knee ahead of your left, knees reflect in inlet position. And anytime I pull my right knee in front of my left, I'm going to be pulling my right anterior inlet forward. And if I pull that forward, I'm going to have to be facilitating my right rectus femoris and my right sartorius. And if I pull my right side forward, I'm going into iliopubo external rotation. So anytime you get into that position, if you write this down on your handout, you're going to helping to facilitate a right rectus femoris and sartorius. And if I help turn those two muscles on, can I not help to inhibit at the same time? Sometimes inhibition and facilitation occur together. Also in your inlet, you have a left iliacus that we want to help turn on. Remember, this was off. We want to help turn it on. How are you going to know if you turn on a left iliacus? What accessory muscles on the opposite side of the iliacus? A left glute med. And if I turn on my left glute med, remember my left glute med helps to pull this into iliosacral external rotation. And if my left glute med helps to get my ilium into iliosacral external rotation, do I not help to put my iliacus in a position to help to adduct my inlet? I will tell you, this is another place where, as clinicians, our patients aren't getting this. I would highlight that. That's frontal plane control. So if you're going to turn on a left iliacus muscle, if you're turning on a left glute med, you're going to be turning on your left iliacus. But you've got to turn on your left glute med as an iliosacral external rotator. You've got to pull your left knee what? Back. So then I'm going to allow my iliacus muscle to work proximally in a frontal plane and learn how to get into left stance. And I don't want my distal iliacus to help me to swing through the air. I want the proximal fibers to help to adduct my innominate bone, my inlet. Yes?
Lori, did you mean the left glute med should be an iliosacral internal rotator?
It's an iliosacral external rotator. Because if I'm pulling right now, if I want to get into left iliopubo internal rotation, it's going to be iliosacral external rotation. It's hard to think about the glute med as an external rotator when it's an internal rotator of our femur. It's the opposite, you guys. Isn't that kind of fun to think about muscle differently? The distal fibers help to internally rotate. The proximal fibers help to externally rotate. We go down to our outlet. We all know that our left anterior outlet is off. You have your puborectalis, your pubococcygeus, you have your obturator internus, and you have your iliococcygeus. What am I going to go after first, guys? What did you color brown? You colored your puborectalis and your pubococcygeus brown. But I'm going to tell you, you're going to kind of get this all together. If I want to turn on my puborectalis and my pubococcygeus, I'm going to help my pelvic floor to ascend by getting my outlet more in an abducted position. So watch. Here's my outlet. Here's a left AIC pattern. If I pull my left knee behind my right, if I pull my left inlet into more iliopubo internal rotation, doesn't it not also help to pull my outlet into ischiopubo external rotation? And if I get in more external rotation, I am abducting my outlet. And if I abduct my outlet, my pelvic floor can now do what? Ascend. So I'm going to help turn on my puborectalis and my pubococcygeus by facilitating more ischiopubo external rotation. Remember, that's a combination of flexion, abduction, and external rotation. And I'm starting to get I'm not trying to create confusion, you guys, but remember, if I go into inlet iliopubo internal rotation, you have to be getting ischiopubo external rotation. So anytime you're going to pull your left knee back, knees reflect inlet position, you're also going to get your outlet to abduct. Let's talk about another accessory muscle that you colored red in your outlet. If I get more left femoral adduction, can I not help my outlet to abduct? Because remember, I told you it has to be opposite or our patients would fall. So if I get more of left femoral adduction, I turn on my left adductor, I'm now going to allow my obturator internus and my iliococcygeus to now to work as abductors of my outlet. So anytime you're turning on a left adductor, you're also facilitating your left obturator internus and your left iliococcygeus muscle to abduct your outlet. We also have to turn on our right posterior outlet. You have a coccygeus, a piriformis, and a glute max. And what great big beefy muscle do you think is going to rule the roost in that situation? Your glute max. You guys are good. So if you turn on your glute max is also going to help to facilitate your coccygeus and your piriformis. So I'm already kind of giving away treatment for tomorrow. What did you color brown in your inlet? You colored your right rectus femoris and your right sartorius. What plane are we going to go after first, you guys? Sagittal plane. And I also told you that the inlet position gives your outlet what? Power. So we're going to go after brown first, and we're going to go after it in that inlet first. What did we color brown second? In your left anterior outlet. Your pupil rectalis and your pupil coccygeus. We're going to go after brown first. And after you get a sagittal plane, you're going to go after frontal plane. And then you've got to go through a transverse plane. But I'm going to give you a PRI test to help know where you need to be in that algorithm. Where's your patient weak? Some of your patients may not need a right anterior inlet. They may already have it. But they may fall apart if they don't have a left anterior outlet. What PRI test is going to help guide your treatment? How are you going to know if your patients are repositioned? And we're going to learn that this afternoon. Do you guys have any questions about the left AIC pattern? Would you guys like me to go through and review it all again before we move on to the PEC pattern? Are you guys good for now? How many of you guys would like me to review? We'll go through it all this afternoon. We'll go through it right before we go through the PRI test, Eric, okay? Okay. Patients that are a left AIC, and then we have people that turn into a PEC pattern. These are individuals, you guys, that start off being a left AIC pattern patient. Underneath every PEC is a left AIC patient. Please remember that. But these are individuals that got on their left leg or tried to get on their left leg, but they got on there incorrectly. So now, instead of having one hip forward, they got on their left leg and now they pulled their right side forward. These are individuals that have a deep arched back. Their pelvises are forward. And these are my runners that run stiff. They don't move a trunk. They don't move a pelvis. They pump their arms instead of having fluidity through their trunk and being able to rotate their trunk. They're stiff. They run with back and hip flexors. They walk on their tiptoes. They're extended. Put a shelf back here. These are individuals that don't even sit on their ischial tuberosities on their feet. They sit on tailbones when they sit in the chair. They have tailbone pain. These are people that get pubalgia because they're splitting their pubic area. These are people that have prostatitis. These are people that have levator ani syndrome. Throw them at me. Because their pelvic floor has a lot of tension. They're no longer alternating. You have both sides that are coming forward. They have a pubic bone, you guys, when you walk. Look at pubic bones of your patients when they walk up and down your hallway. They don't move. Your pubic bone, when you're going in a right stance, should go to the right. It should go to the left. They stay stuck in the middle. They're rigid. They've lost transverse plane movement. They are stuck in a sagittal plane. They don't have frontal. They don't have transverse. This is a chain of muscle. When we talk about a PEC, it's a posterior exterior chain patient. This is a chain of muscle that we talk about. You have the latissimus dorsi, the quadratus laborum, the posterior intercostalis, your serratus posterior, the iliocostalis lumborum, and these are the muscles here. And see how when they get overactive, they're going to pull that pelvis what? Forward. They're also going to help to pull your ribs what? In the back? Down. They're being pulled together from the back. This is being pulled open. This is a view of your pelvis from the front of the PEC pattern patient. So on both sides, you don't have one side that's going forward and one side that's going back like you do in a left AIC. You have both sides that are doing what? Coming forward. So both sides are going to be into flexion, external rotation, and abduction. So anteriorly, they're stuck in iliopubo external rotation. So if anteriorly I'm in iliopubo external rotation, posteriorly I'm going to be stuck in iliosacral internal rotation. There are patients that have pain right back here. They're being compressed at their SI joint because their ilium's moving their sacrum into internal rotation. Their sacrum is going to be more, it's going forward, it's going flexed in the inlet. So anteriorly, we're going into iliopubo external rotation. Posteriorly, we're going into iliosacral internal rotation. And your sacrum is no longer has a transverse plane going into internal and external rotation on either side. You have a sacrum that's stuck in a sagittal plane, so it's going into what? Flexion. So if you go over here and you look in your circle on the opposite side on page 27, I want you to write, you can see your anterior sacrum is flexed. Your posterior inlet is in iliosacral internal rotation. Your anterior inlet is in iliopubo external rotation. And the right side is the same. So from my sacral base to my ASIS bilaterally is being what? Pulled apart. My anterior inlets this is being pulled forward. These are being pulled together. The arrows are coming together in the front. The arrows are being pulled apart in the back. The rectus femoris and sartorius are pulling them what? Forward. So my posterior inlets are going to be what? Off. They're long and weak. My arrows are being pulled together positionally from the front because my ASIS is being pulled forward. So my rectus femoris and my sartorius are going to be on. So now we know what muscles are back there. We discussed that. If you guys want to write them in again, you can. Your iliacus, remember, is posteriorly, and anteriorly would be your rectus femoris and your sartorius. So your anterior inlets are on, and your posterior inlets are off. If we go back and we look at our outlet in a PEC pattern, if my front side is being pulled forward and going to ischial-pubo external rotation, my back side has to be going into ischial-pubo internal rotation. So it's going into flexion, adduction, and internal rotation. It's being pulled together. they have tight butt syndrome. You see that back there? But look, their sacrum, you guys, isn't going from one side to the other. My sacrum in the inlet is going into flexion, but in my outlet it's going into extension. And if this is going into flexion, same bone, this is going into extension, my tailbone has to curl under me, and I have to go into flexion, and guess what I sit on? Tailbone pain. I don't sit on my ischial tuberosity that's meant to take weight. It's being pulled in. I have to now sit on a tailbone all day when I sit in front of that computer and work. So your anterior outlets are going to be what? Off. Your posterior outlet is going to be on. You have your position on page 28. If you go to your circle on page 29, your anterior outlet is going into ischio-pubo internal rotation. It's going into flexion, adduction, and internal rotation. You don't have to write anything back here because your sacrum can no longer has a transverse plane. You don't have SIIR or SIER because your sacrum is stuck in a sagittal plane. So you're going to see how your sacrum is extended and your coccyx is flexed. We move the bar down here because this is going to be long and open. And their center of gravity is going to be coming forward in the inlet and back in the outlet. So, your anterior outlets are going to be off, and your posterior outlets are going to be on. So my pelvic floor, remember, I taught you that if you have an outlet that is stuck in adduction, and this is being pulled close, your anterior outlet is going to be more what? Descended. They have pelvic floor pressure. How do you hold up organs? It's in a lengthened position. They now have to use their lengthened adductors and their back to try to help pull up their anterior outlet. Because their outlet is in a position to help to support pressure, gas, internal organs. It's in a descended position. Those muscles can't help to support them. So here's your summary. Your inlet bilaterally is an iliopubo external rotation. Your inlet is an iliosacral internal rotation. So we're going into external rotation anteriorly, abduction, internal rotation back here. They're getting compressed in their SI joint. And their outlet, your ischium is moving into internal rotation, adduction, and extension. When you adduct your outlet, your pelvic floor is going to be descended. It's going to be hypertonic and inflexible. They have a lot of tone. They feel like stuff is falling out. They have a lot of pressure. This is why you can have a 6'5" volleyball player that can jump 2 inches off the floor. My pelvic floor comes up, I'm going to have more power to jump higher. If I have pressure and I'm bearing down, how do you jump higher? How do you get a bigger vertical? How do you walk forward? Any questions with the PEC pattern? Then we're going to go to a patho-PEC. But before we do that, let's talk about our goals of our PEC. I taught you with your left AIC that we want to get those individuals more alternating. They've got to be able to get from right stance to left stance. With your PEC pattern patients, you're going to have to get them more reciprocal first before you get them alternating. So if they're going into flexion with their inlet bilaterally, they've got to learn how to extend. If they're going into abduction, they've got to learn how to adduct. If they're going into external rotation, they've got to learn how to internally rotate. In the outlet, if they're in adduction and extension and adduction and internal rotation, they've got to learn how to flex, externally rotate, and abduct. They've got to do opposite. So you got to get reciprocal before you get alternating. Here's your circles of what we talked about. So we got to make our offs go on and our ons go off. So think about this, you guys. You guys want to do stuff that's going to help to do a posterior pelvic tilt. These are people that are stuck in an anterior pelvic tilt. They've got to learn how to do opposite. And if I turn on my adductors by putting a ball between their knees, which I know some of you have seen in some of our exercises, and if I adduct my femurs, what's my outlet going to do? Abduct. So now I've taken it from being here, and I put a ball between their knees, and I kind of turn on their adductors. I'm going to make them come here. And once I teach them how to do this, then I can make them more what? Alternating. And do I want to teach them how to do left stance, you guys, or right stance? Thank you. Because underneath every PEC is a left what? AIC. Every patient starts off being a left AIC pattern patient first. So your algorithm of treatment is going to be going to get them more reciprocal, and then they've got to get alternating and learn how to get into left stance, and then we've got to get them alternating back and forth. If my inlet is going into flexion, and I want to help to teach remember I had you guys underline this earlier. I'm looking at you, Christy, because you asked me about it. What muscle do I want to emphasize with my PECs? If I want to get more left inlet extension, IOs and TAs. Because my IOs and TAs, remember, attach more distally, and they're going to help to pull my pelvis what? Back. So I've got to turn on my IOs and TAs in a sagittal plane to help to extend my inlet. Because if I extend my inlet, I'm going to flex my outlet. And if we don't inhibit the anterior inlet by using abs, you're going to have patients that can't shift or get into left stance without extending a what? Back. They've got to be able to close this down. They've got to have abs. And I think we do a good job, you guys, of teaching our patients how to blow up balloons and pull ribs down. But I don't know if we're getting the piece of how we need to pull our pelvis back with inlet extension. I'll give you tips on how to do that with treatment. Inhibiting an anterior inlet is where I've made mistakes with my patients. And I told you I'm a clinician first. I want you guys to learn from my mistakes so you guys can get from point A to point B quicker than I did. I want you guys to learn from me. Because I'm not up here saying I'm the best PRI therapist. I am not. I've made many mistakes, and I want you guys to learn from them. And this is where I've missed the boat. I progressed too quickly through this. Once you get them to get more reciprocal, you want to get alternating. So you want to go back to all the stuff that we reviewed before. You want to turn on a right rectus femoris sartorius. You want to turn on a left iliacus via glute med. You want to turn on a left anterior outlet via a left adductor and a left ischio-pubo externally rotated position of your outlet. And you want to turn on a glute max. That's all the stuff that we've talked about right here. Once you get them into right AIC or left stance, then you've got to get them alternating. Left leg, right leg. Left leg, right leg. So you're going to understand our outline of our treatment tomorrow. Any questions with the PEC or goals? Now we're going to go underneath the patho-PEC. Your patho-PEC, you guys, think about these people as maximizing in-range position. Your PEC has kind of gone from being forward on both sides, kind of like medium on a stove. Your patho-PECs are on high. They are at in-range position. So they're not coming a little bit, they're coming forward, but they're going maximally forward. Because these are individuals that are so unstable that they have to maximize in-range position for support. So if I'm straightening my elbow a little bit with my PEC, your patho-PECs are coming all the way out. They have to lock in. Look how hypermobile I am. I have to lock into my elbow. Instead of using my tricep muscle, I'm going to lock into my elbow and extend my elbow to help to support me. They're in the same position as the PEC. So their anterior inlet is going into flexion, external rotation, and abduction. Their posterior inlet is going into iliosacral internal rotation. Their sacrum is still flexed. From the anterior view, you're going to see how they're splitting here at the side joint anteriorly, just being more compressed posteriorly. They have a lot of back pain, have a lot of pathology. So here's the posterior view. So if you look on page 34, and if you look at your inlet, your posterior inlet is in iliosacral internal rotation. So I want you to write ISIR in your posterior aspect of your circle on page 34. Your anterior inlet position is iliopubo external rotation. Remember, that's the combination of triplanar motion of going into flexion, abduction, and external rotation. Notice that with your patho-PEC compared to your PEC, that the horizontal line going from the ASIS to ASIS is going down more anteriorly because these individuals are maximizing in range position. So your arrows are being pulled apart from your sacral base to your ASIS on both sides. But even anteriorly, those arrows are going to be pulled apart from your pubic symphysis to your ASIS because they are maximizing in range position. So they're going to start to stretch out ligaments, soft tissue. Your sacrum is still flexed. And if my sacrum is flexed, guys, what does my lumbar spine have to do? Extend. They have a really deep arched back. They use their back for stability. That's why a lot of them have back tension, back pain. So your posterior inlets are off, and your anterior inlets are off. When you think about the PEC and the patho-PEC, I want you guys to think about soft tissue. Now, don't misunderstand me, but if you're in an in-range position, I just showed you how my tricep muscle really isn't working if I maximize an in-range position. Even though my elbow is straight, my triceps still can't work. They aren't using muscle to help to support them anymore. They're using joints. They're getting their support through an SI joint. They're getting it through a back. Everything is off.
Would you expect somebody in a patho-PEC pattern to have ligament integrity issues?
Yes. He asked if they would have ligament integrity issues. Yes. And when we go through our testing, that's how you're going to differentiate, Tom, if they're a PEC or a patho-PEC. Because they're going to have stuff that they can do that they shouldn't be able to do. They stretched out through soft tissue in order to be able to do it. Nice job. If we go down to our outlet, your outlet, remember, if we're going into in-range position, your anterior outlet is being pulled into ischio-pubo-internal rotation, or it's going into extension, internal rotation, and adduction. Your sacrum no longer has transverse plane. It's still going into extension, and your tailbone is still going into flexion. So if you have your circle on page 36, you're going to write about ischio-pubo-internal rotation. You don't have anything posteriorly. You don't have transverse plane anymore. But you do have a sacrum that's extended and a coccyx that is flexed. And everything is off. These are individuals that are more comfortable sitting on something because they get the support of their pelvic floor. Because they feel like they're falling out. Think about pubalgia, you guys. If I'm maximizing in-range position, look at how my pubic bone is splitting apart. This is your summary. It's the same as the PEC. But with these guys, I want you to think that their pelvic floor, yes, is descended, but I want you to think about bulging. Think about your PEC as kind of being more rigid, like a board with their anterior pelvic floor. These individuals are like a hammock. They're starting to stretch out because of the in-range position. They feel like they're falling out. So your pelvic floor is going to be more bulge, and they're going to have a high resting tone. Just because something is lengthened doesn't mean it doesn't have tone, because they're trying not to fall out. They still have to support organs. They still have to support gas. They still have to support pressure. And they have a high resting tone in these individuals because they feel like they're falling out. You still want to create a reciprocal and alternating pelvic floor. You have everything that is off. You still want to go after a posterior pelvic tilt and abs with these individuals. But you guys could spend a few sessions on this step. I spent 2 sessions just teaching one of my patients how to breathe, let alone doing a pelvic tilt. Just telling you from my standpoint, I skipped this step too quick. I've gone after a left adductor too fast. I'm not saying that's not important, but you better get some abs on these individuals to help get them in a better what position. And I'm going to give you objective tests to know when you can move on, because it's more about than just doing an adduction drop test. We have a lot of great PRI tests. I want your test to help guide your treatment. You have an adduction lift test that we're going to talk about today. You're going to learn about a pelvic ascension drop test today. You're going to learn about a passive abduction raise test today. All those tests are going to help guide your treatment. All an adduction drop test tells you, for those of you that haven't been there, you're going to learn, is to tell if you're in the right what position. But if you get your patients in the right position, how do you know what you have to facilitate? What test is guiding your treatment? Have a little attitude about it. Can you tell? Because I've made mistakes too. I want you guys to get your patients from point A to point B quicker instead of picking through 500 PRI activities, what I do with my patient now. But wouldn't it be nice if you had a test that said, they need a left glute med. And you go after a left glute med section, or you need a left iliacus, you're going to have a left iliacus section in an UCD. Wouldn't it be nice to know if you have a test that tells you you need to do that that's where your patients need help? I would just highlight this. You're going to be there for a while. After you get that, then you want to get them more alternating. You want to go after the left adductor. You want to go after the left glute med. You want to go after the right rectus femoris and sartorius, all the stuff I taught you. But if you skip from this step too quick, they're going to lock up. They're not going to stay repositioned. If you progress these people too quickly, they're going to go right back to here, and they're going to feel worse. And now PRI doesn't work. PRI has failed. But it's not the patient. We're progressing them too quickly. We might have to think about inhibition of a back. I will tell you, these guys love their hip flexors. Hip flexors help pull spines forward. Any questions with the patho-PEC? Yes?
Like you have a patho hip, like a lot of dancers or people have blown through that. I know hold control is important, but how does that affect the integrity of like the pelvic floor and the pressure on the outlet and inlet when you don't have that capsular ligamentous support?
You're going to have objective tests. They're probably patho-PECs. They're going to have tests that they can do, John, that they shouldn't be able to do for the pattern that you know that they're in. So in your situation, if you're talking about a Myokine principle with an integrity of a hip, they'll have an adduction drop test that's positive on both sides, but they'll have an extension drop test that's negative. So they can do something that should be positive when it's really negative. I'm going to show you some different tests that you're going to see with those individuals this afternoon. Yes. They're stretching out tissue. They're stretching out ligaments because they're at in-range position. That's how you're going to know you have a difference between a PEC or a patho-PEC. Whenever you think about pathology, there are individuals that can do something they shouldn't be able to do with their PRI tests. And well, I think that'll make better sense this afternoon when we go through our testing. I want to kind of go through a research article, and this is all available on the PRI website. This is an article that a course attendee had sent me, and she kind of wanted to understand how it was different. And really, this article is a great support of a difference between a PEC and a patho-PEC. What this article looked at, you don't have to read, this is all on the website, so you don't have to worry about this. This is all written about at PRI, so don't worry about writing it all out. This is my rebuttal to her. She sent me a question. She sent me a copy of the articles, and this is what I wrote back to her. What these two articles looked at, you guys, is both of the patients in the group. You had a group 1 and you had a group 2. In both situations, they were looking at an angle here with lumbar extension, and they were also looking at an angle from the pubic symphysis down. And what they found in a group 1 is that both groups, the LL1 or the back extension, was the same. But what they found with the angle down here is that individuals who had, with their angle got bigger, they actually had more prolapse, more incontinence, and more pelvic floor problems. Well, what happens is that supports a PEC and a patho-PEC position patient. Group 1 was your PEC patient. They had the large angle here, they had the increased lumbar extension, and they had the angle down here that was more tight or closer together because it's being pulled forward. But your patho-PECs, you guys, start to kind of come back. They can get kind of kyphotic because they're trying to get support, and they kind of come and hang out on their wide ligaments, John. So this angle actually with them, you guys, got bigger, but guess what? They're still what? Extended. They're trying to get more support by pulling forward. So as this angle got bigger, they had more incontinence and they had more prolapse. So her question to me was about, this article said that lumbar extension was good. We don't want more. They were both still in extension. This angle got better, but that didn't equate to more extension up here. Now, in the second article that was listed up there, they looked at the same thing, and they found the same thing. Lumbar extension. This is a review of the other article. They had the LL angle, and they were both, it was at 42.4 degrees of extension, but the LL angle in the second article was less, but it was still more than normal. Normal lumbar extension is 0 to 30 degrees. They still had increased extension of their lumbar spine. But in group 2, this is a group that was a patho-PEC, they got more sway back and they hung on their wide ligaments because they have to come back here. So they lose a little bit of extension, but they're still extended, but they have to come back and hang out here because they have to maximize the interrange position because they don't have muscles to what? Support them. They're trying to get more stability. So they're going to take their thoracic spine and come back. They're going to come hang out on their wide ligaments. So this angle gets bigger, but they're still extended in their lumbar spine. So I'd encourage you guys to look at that. Kyphosis is talked about more in our advanced integration course, but I would encourage you guys to look at these two articles with how they support a PEC and a patho-PEC pattern. Yes?
So in the studies when I ran into, there was no control group that wasn't already had incontinence issues, right?
One group didn't have incontinence, but the second group had more incontinence and more prolapse. There was one group that didn't have, I think it was the first article, Cherie. The first control group that was a PEC pattern didn't have prolapse and they didn't have incontinence. And what they found is that the second group had more of a prolapse and incontinence. It's been a while since I read them, but I think I remember that correctly. The second article, it may have been more, but it went up at the second group with the patho-PEC group.
So basically, in the first group, there's still muscular tension holding the pelvic floor up.
Yes.
It's just not optimized.
Yes.
In the second group, it's also not optimized, but now there's no longer muscular tension. So
Right. Yes. Everything's off. Any questions at all? I just thought I'd throw up some research to help support some PRI concepts. Did you have a question, Carol? I'm sorry, I saw your arm come up. Okay. Before we get in, we're going to get into these tests after lunch. So before we go to lunch, we're going to go through and review our morning. Okay? We come back after lunch, we can hit our tests. Because it's a lot of information to go through in about 3.5 hours. I don't expect you guys to remember everything. I'm just opening it. By tomorrow, I hope you get it. But I hope that your manual is set up in a way, you guys, so you could go back and look at it and study it. The goal isn't for you guys to be proficient about what's in the left anterior inlet today and what's in the right posterior outlet, but are we providing you the information that you can go back and study your manual and be able to look at that and be able to apply it. I don't expect you to be rocket scientists right now, but I wanted you to fill out the circles and look at them so you can pull them out tomorrow when we go through treatment. In a left AIC pattern, we're going to think about Emily. And Emily this morning, at about 8:20 this morning, stood in front of you on her right leg with her left inlet coming forward and her right inlet going back. That was a great thing for her to do on her right leg, but she also did it on her left leg. This pelvis was still forward, this was going back. Her pubic bone was still going to the right, even when she was on her left leg. She thought her weight was back on her left leg, right? Until she had a therapist come back to help pull her back here, and boy, that feels weird. And now she learned how to go back into left stance. In a left AIC pattern patient, their position of their left inlet anteriorly is going into flexion, external rotation, and abduction. Posteriorly, their ilium is moving on their sacrum into internal rotation. In a left AIC pattern patient in the inlet, when my left side is coming forward from my sacral base to my left ASIS is being pulled apart. My left iliacus is long and weak. In my anterior inlet, from my left ASIS to my right pubic symphysis is being pulled together. My arrows are coming together. So my left rectus femoris and my left sartorius are on. They're short and strong. On the right side, from my left pubic symphysis to my right ASIS, that's being pulled apart. So you colored on your right side, your right rectus femoris and your right sartorius that attach here, because we want to help bring our right side forward. They're long and weak. Your iliacus on your right side is short and strong with adduction. We talked about some important accessory muscles of our inlet. We talked about our glute med as a transverse plane muscle you colored in orange. And your glute med on the left side is going to help take my ilium on my sacrum and move it into external rotation. And if I get iliosacral external rotation, I'm also going to get iliopubo internal rotation. I'm moving back. We also want, as a transverse plane muscle of our iliacus, we also talked about an important muscle over here that you colored purple called our right glute max. And your right glute max on your right side helps out with iliosacral internal rotation. So if I'm pulling my right side forward with my right rectus femoris and sartorius, my glute max is going to be on at the same time to help pull my ilium into iliosacral internal rotation. They work together. I need to be able to bring my right glute max to help bring my right side forward in order to get into what? Left stance. We also talked about an important accessory muscle or integration muscle that's going to help to extend my left anterior inlet. Remember, my inlet on the left side is going into flexion, external rotation, and abduction. Your IOs and TAs help to extend. They help pull this in. And if you don't get your IOs and TAs to work in a sagittal plane and you can't pull this back, you're not going to get your left iliacus to work as an adductor. You're not going to get your outlet power either. If I can't inhibit my left anterior inlet, I can't help my right anterior inlet to what? Turn on. When we talk about inhibition tomorrow. Any questions with the inlet? With review. We talked about the muscles. You're going to turn on a left iliacus via a left glute med. You're going to turn on a right rectus femoris and sartorius by pulling my right inlet forward. We go down to our outlet. In your outlet, in a left AIC pattern patient, if my left anterior inlet is being pulled into flexion, external rotation, and abduction, my left outlet is going into extension, internal rotation, and adduction. It's opposite. My sacrum is moving into internal rotation. It's going into sacral ilio internal rotation. That position of adduction makes my left anterior pelvic floor, my puborectalis and my pubococcygeus muscle be in a descended position. My obturator internus and my iliococcygeus muscle are not in a position to help to abduct my outlet. My glute max and my piriformis and my coccygeus on the right side are long and weak. They can't help pull my sacrum from being oriented to the right to help it to be oriented to the left to help me get into left stance. We need to turn on our right posterior outlet and our left anterior outlet. We talked about two important accessory muscles, in addition to the ones we just discussed, to help our outlet out. We have to turn on our left hamstring muscle to help to flex or take our outlet into ischiopubo external rotation. You colored it brown. You also have another important accessory muscle that's going to help out our left obturator internus and our left iliococcygeus muscle to help me to abduct my outlet. Because if I abduct my outlet, my pelvic floor then can ascend and I get more power whether I want to jump, walk, or run. And I'm going to get more power by that by turning on a left adductor. Because it's all about the frontal plane. I've got it in order for my patients to learn how to get into left stance. They've got to learn how to adduct a femur. They've got to learn how to abduct an outlet. And they've got to learn how to adduct an inlet. And they've got to learn how to get into left stance, not by going out, not by going back, not by extending it back. They've got to go back at a diagonal. And they've got to be able to keep inlet extension, control. We're getting our patients up too quick, you guys, because they're learning to get into the left stance by extending back. These are people that are coming forward. If you come forward, they have to have a hemilordosis on the left side. Every time they take a step, they extend their back in order to pull themselves around to walk forward. I want your patients to learn how to take a step, and they've got to be able to close down an inlet and extend it. So now my inlet can adduct with the glute med and abduct my outlet with an iliococcygeus and an obturator internus, so I can learn how to push myself forward with a butt versus pull myself forward with the hip flexor on the right side. I get a little passionate. Any questions with the left AIC? Then we talked about a PEC pattern patient. Stephanie, could you come up here? I might as well pick on people, right? If you have Stephanie stand in front of you and she puts her left foot forward and stands back on her right leg. I'm not trying to get personal, but here's she's on her right leg and there's that pubic bone right in the middle. And if Stephanie gets back and gets on her left leg and puts her right foot in front of the left, there's her pubic bone right in the middle. She is a PEC pattern patient. She'll stand from you from the back. She has a nice deep arched back. Look at this nice little shelf we have back here of her sacrum. This is being pulled down tight. This is being pulled apart. Think about Stephanie when you think about a PEC pattern patient. I'll pull her up this afternoon and show you. Don't you like it? I get a pic of you. Sit down. So in Stephanie's situation, she's lost the ability to be alternating. She's lost her ability to be even reciprocal. Now both sides are forward. Her pubic bone can't move. In Emily's situation, her pubic bone can at least go to the right. But Stephanie worked really hard to get on her left leg and pulled her right side forward too. Because she didn't know how to get on her left leg and pull her left side what? Back. So she pulled her right side forward, and now her inlets are in a position of ischio-pubo-external rotation on both sides. Her anterior inlets are on. And her posterior inlet, she's in iliosacral internal rotation. She'll get tightness back here. Am I right? Yeah. It's not about me being right, but just asking. Doesn't mean that they have a herniated disc pain, but they'll get tight after doing a lot of work. In her outlet, her ischiums are moving into internal rotation, adduction, and extension. Her anterior outlet is off. If she's going into adduction, both sides of her pelvic floor are now descended. Her posterior outlets are on. Tight butt syndrome. These individuals, in order to help them get more reciprocal, I taught you that I want you to think about abs, a posterior pelvic tilt, and adductors. But adductors with the pelvis in a reciprocal position, not in left stance or right stance. I never told you to go after a right adductor. I told you to go after adductors with my patient in a posterior what? Pelvic tilt. Because if I get my adductors on, I'm going to get both of my pelvic floor to do what first? Ascend. I'm going to get a more reciprocal first before I get alternating. You do not want to go after a right adductor with a PEC pattern patient. Because underneath every PEC is a what? Left AIC. Please don't go out and do that and say that I taught you how to do that. It'll ruin your program. Now you're going to create a left AIC pattern patient. We went from a PEC and we talked about a patho-PEC that's in the exact same position that we just talked about. But these are individuals that are maximizing in range position. So instead of coming forward a little bit, they're maximizing in range position. So they're getting more support through an SI joint. They're getting more support, John, through ligaments. They're getting more support through back extension because her soft tissue is no longer, Tom, what? In a position to support them. So everything is off. Their pelvic floor is bulging and descended. They have high resting tone. These people are a mess, to be quite honest with you. They're not going to be getting them done in 5 visits. Any questions? It's a lot of information. I know it is. Why don't we take a lunch break? And does anyone have any questions before we break? Why don't we meet back here at 1 o'clock? Okay? Have a good lunch.